Welcome back. Let's talk about how to insert a pulmonary artery flotation catheter. When we insert a catheter into a vessel, we can measure the pressure, whether it happens to be in a vein or an artery. A balloon inflated at the tip of this catheter allows the blood flow to carry it in the right direction. As we advance an intravascular catheter, say, towards the heart, we know its location because of the pressures and waveforms characteristic of that vessel or chamber are conveyed from the tip of the catheter all the way to a monitor in which we can see the waveform and we can measure the pressure. And this information provides the basis for understanding the pulmonary artery flow-directed catheter. Refer to the series of photographs and these images to my right. First, we need to remove the pulmonary artery catheter from its packaging and hand the proximal end of the catheter to an assistant. Place the sterile sheath over the catheter. Flush all ports and channels of the pulmonary artery catheter with sterile heparinized saline. Check the balloon after sheath placement, as this has been known to cause balloon damage. The distal port should be connected to a transducer and zeroed at the patient's mid-axillary line. Make sure that the pressure tubing is free of air bubbles. Test the transducer system by occluding the tip of the catheter with your finger. The pressure waveform should rise gently. Then give the catheter tip a small but vigorous whip and check for high amplitude, high frequency oscillation of the pressure waveform. This is a sensitive test for damping due to air bubbles in the line, but it also illustrates how very incredibly sensitive the pressure trace will be to motion artifact when you're inserting it. From this point onwards, the position of this pulmonary artery catheter is determined by continuous observation of the pressure waveforms recorded from the tip of the advancing catheter. The pulmonary artery catheter is inserted gently into the introducer with the balloon down, of course, and advanced until it emerges from the distal end of the introducer sheath, approximately 20 centimeters, and at this point an assistant can inflate the balloon. The pulmonary artery catheter should be in the superior vena cava or either the right atrium at this point, depending on the patient's height. The pressure in the superior vena cava or right atrium is referred to as the central venous pressure. Normal right atrial pressure and waveform are shown here. Once the tip is in the right atrium, the pulmonary artery catheter should always be advanced with the balloon inflated. This will allow the flow of blood to carry the pulmonary artery catheter forward, as well as preventing damage to sensitive intracardiac structures. Conversely, the pulmonary artery catheter is always withdrawn with the balloon deflated. The balloon is inflated. The pulmonary artery catheter is advanced across the tricuspid valve and into the right ventricle, which occurs with a sudden increase in systolic pressures. Of course, the diastolic pressure remains the same. The right ventricle is entered at approximately 30 centimeters. Once in the right ventricle, the pulmonary artery catheter should be quickly advanced. When the catheter crosses the pulmonic valve and enters the pulmonary artery at about approximately 40 centimeters, the diastolic pressure abruptly rises, and sometimes a dicrotic notch can be seen on the waveform. Right ventricular endocardial irritation may result in cardiac dysrhythmias, and monitoring of the ECG at this point is crucial. Should ectopy occur, the pulmonary artery catheter may be quickly advanced out of the RV into the PA or immediately withdrawn with the balloon deflated, of course. The pulmonary artery catheter is advanced until a pulmonary capillary wedge pressure, or PCWP, or simply wedge position is obtained. This is heralded by the disappearance of the systolic component of the waveform. This occurs at approximately 50 centimeters. The balloon is deflated. The PA pressure tracing should reappear at once. If it does not, withdraw the pulmonary artery catheter until safely out of the wedge position. Secure the sterile sheath proximally to the introducer port and distally to the PAC with sterile tape. The balloon is always kept deflated, being only inflated briefly to obtain a wedge pressure. overzealous balloon inflation may result in pulmonary artery rupture, and prolonged inflation may result in pulmonary infarction. Apply a sterile dressing. Correct placement of the pulmonary artery catheter should be confirmed by a chest X-ray. Now, having considered the technicalities of successful clinical insertion of a pulmonary artery catheter, let's look at how we can use it. Applications of the single common chamber concept. Now, in this section, I'm going to ask you to use your imagination in order to facilitate understanding of the function of the pulmonary artery catheter. It's essential that you appreciate that the entire pulmonary circulation has a very low vascular resistance of about 150 units, which is approximately 1/10 of the systemic vascular resistance. The implication of this is that if the pulmonary artery pressures were much lower, the left-sided venous pressures have no problem traveling retrogradely all the way to the large pulmonary arteries. In this image, we see bright red vessels arising from the pulmonary artery and providing blood to the alveoli. Now yes, we know that the blood in the pulmonary artery is deoxygenated blood, but I am going to stick with convention of using red for arteries and blue for veins. Now, to understand how the pulmonary artery catheter works, just imagine that we can separate the right side of the heart from the left side of the heart, and we have flipped the pulmonary veins over to the right, so separating them from the pulmonary arteries. And so now the pulmonary arteries and pulmonary veins are separate, and we have the right side of the heart on the left side of the image and the left side of the heart on the right side of the image. And we see a pulmonary artery waveform with a pressure of approximately 25 millimeters over 10. And now on the pulmonary venous side of the circulation, we see the normal pulmonary venous waveform, which is reflected backwards from the left heart, and it is a very low pressure waveform. In this image, we see a pulmonary artery catheter in the pulmonary artery, and the tip is located in a small pulmonary artery, and the balloon has been inflated. With the balloon inflated, the high pressure pulmonary artery waveform cannot pass beyond the balloon because the balloon's in contact with the walls of the artery. With the balloon inflated, we can isolate a small segment of the pulmonary circulation from the higher pulmonary artery pressures, so the left-sided pulmonary venous pressures can travel retrogradely all the way back to the tip of the catheter, which can now register left-sided pulmonary venous pressures, referred to as the pulmonary artery occlusion pressure or even pulmonary capillary wedge pressure. Here we see the A wave, the C wave, and the V waves of the normal left-sided venous waveform. So this is amazing. A right heart catheter giving us a left-sided venous waveform. But these waveforms and their nomenclature will be fully explained in the section on the venous system, normal and abnormal venous waveforms. So, I like to think of the pulmonary artery catheter as getting us in through the back door of the left heart in order to measure the low pressures in the pulmonary venous system, and the arterial catheter as getting us through the front door to measure arterial pressures in both systole and diastole. Interestingly, the multiple lumens in the pulmonary artery catheter allow us to simultaneously measure ventricular pressures and central venous pressures simultaneously. So, having all this information, the central venous pressure is an index of right ventricular preload. The pulmonary artery pressure gives us an index of right ventricular afterload. When we inflate the balloon of the pulmonary artery catheter, we get pulmonary artery occlusion pressure or pulmonary capillary wedge pressure, and these can act as an index of left ventricular preload. And of course, the arterial line measures systemic arterial pressures, and this gives us an index of left ventricular afterload. The pulmonary artery catheter can also provide thermodilution cardiac outputs, and with this arrangement we are able to calculate a whole range of derived hemodynamic variables which can provide diagnostic information which can help us manage left or right heart failure or pulmonary hypertension or problems with oxygen supply and demand. And we can do this in intensive care patients or in patients in the operating room or doing separation from cardiopulmonary bypass in the cardiac suite. So, the pulmonary artery catheter can be a very, very useful tool in our sickest patients. Let's talk about how the pulmonary artery catheter can extend the single common chamber. The pulmonary artery catheter may be introduced into the venous system via any large vein, such as the femoral or the subclavian or the internal jugular. So let us assume we have inserted this pulmonary catheter, also known as a right heart catheter, into the right internal jugular, and then we connect a pressure monitoring line to the lumen which goes to the tip of the catheter, and we zero the line and then ensure we have a functional pressure trace. Now we witness a central venous pressure trace with a central venous pressure of approximately 5 millimeters of mercury. We inflate the balloon at the tip of the catheter and we cautiously advance the tip of the catheter into the SVC and then the right atrium, and these chambers give us essentially the same undulating waveform and with a mean central venous pressure of about 5 millimeters of mercury. When we insert this catheter between 15 to 20 centimeters, we'll see a dramatic elevation of the pressures to about 25 millimeters of mercury in systole, falling back to 5 millimeters of mercury in diastole. So we are in the right ventricle. We keep advancing, and as we leave the right ventricle and enter the pulmonary artery at about 20 to 25 centimeters, there is no change in the systolic pressure, but the diastolic does not decrease all the way back to 5 millimeters of mercury, but is supported at a higher pressure of 10 millimeters of mercury. The variation of pressures from 25/10 with a mean of 15 millimeters of mercury indicates that we are now in the main pulmonary trunk. We keep advancing, and the balloon at the tip of our catheter will lodge snugly and gently against the walls of an artery. So, the pulmonary arterial waveform with pressures of 25/10 completely disappears because there is no high pressure arterial blood flowing past the balloon, and the blood distal to the tip is shielded from high pressures. In fact, from the tip of the catheter through the remaining portion of the artery, through the smaller arterioles, through the pulmonary capillaries, and all the way to the pulmonary veins, there is stasis of blood. There is a long column of blood which does not flow because the balloon is inflated, and it insulates the tip from the more proximal, higher pulmonary artery driving pressures. But in diastole, there is a continuous pathway from the left ventricle through the left atrium, through the pulmonary veins, and through the pulmonary capillaries, and to this distal segment of protected artery when the balloon is inflated, and we get to the tip of the pulmonary artery catheter. So as there is stasis of blood in this entire pathway, the pressure in the left ventricle must equilibrate with the pressure at the tip of the catheter, and this is now functionally a single common chamber. And so here is the magic. The tip of the right heart catheter is reading left heart pressures. This is another application of the concept of the single common chamber, and the left ventricular diastolic pressure in health will usually be about 6 to 12 millimeters of mercury. And this is termed the pulmonary artery occlusion pressure. Wow. Cardiovascular physiology. It really is amazing, isn't it? What we have done by inflating the balloon of the pulmonary artery catheter is to allow the single common chamber for the pulmonary veins, the left atrium and the left ventricle in diastole, to extend all the way back into the pulmonary arterial system. So let's look at some real-life insertion of pulmonary artery catheters and the traces they produce. The first thing you're going to notice is the incredible amount of whip because the pressure transducers are so incredibly sensitive. Now here we see the central venous pressure trace. The numbers are unreliable due to the amount of whip, so we rely almost entirely on the waveform to know where we are. Here we are in the right ventricle. Now we are in the pulmonary artery. Now we see the catheter going into the wedge position. Now once again in this trace we see lots of whip. So this trace may not look like much, but it's a central venous pressure trace.
Now carefully study the morphology of the waveform. Here we see a right ventricular pressure trace, and as we advance further, we see a pulmonary artery pressure trace.
Now, time to move on. We're going to talk about intraoperative monitoring for myocardial ischemia in the absence of having transesophageal echocardiography. I'll explain all of this shortly. Induction of general anesthesia and endotracheal intubation can be very hemodynamically destabilizing, but can be particularly dangerous in patients with severe coronary artery disease. And these patients often present for coronary artery bypass grafting. Such hemodynamic instability can lead to possibly life-threatening myocardial ischemia. Now, conventional monitoring for myocardial ischemia with an EKG misses many episodes of ischemia, and it's inadequate for this purpose. An alternative monitor is the use of transesophageal echocardiography for the detection of wall motion abnormalities. Transthoracic echo cannot provide the continuous images during induction of anesthesia, and so it does not serve for this purpose. Transesophageal echo cannot be inserted into a patient until after the patient is asleep, and so this is inapplicable at the time of our greatest need for ischemia monitoring. We need an ischemia monitor which is better than EKG monitoring and can be initiated prior to induction of anesthesia. Many coronary artery disease patients presenting for aortocoronary bypass grafts will have a pulmonary artery catheter, also known as a right heart catheter, inserted for ischemia monitoring prior to induction of anesthesia. Well, how on earth would this work? What can a catheter in the pulmonary artery tell us about what is happening in the walls of the left ventricle? Now, recall previous presentations on diastolic relaxation and diastolic dysfunction. We know that when left ventricular muscle becomes stiff, higher pulmonary venous pressures are required to fill the ventricle. A well-recognized cause of this decreased ventricular compliance is myocardial ischemia. Should these patients develop myocardial ischemia during induction of anesthesia, the pulmonary venous pressures will increase and can be detected by the tip of the pulmonary artery catheter. Initially, the onset of myocardial ischemia will lead to increases in left ventricular filling pressures, which can be detected after inflation of the balloon at the tip of the pulmonary artery catheter. More severe ischemia can cause pulmonary venous pressures to rise higher than normal pulmonary artery pressures, and this can present as severe pulmonary artery hypertension. During induction of general anesthesia, we expect to see a gradual decrease in pulmonary artery pressures, but if we see rising pulmonary artery pressures, this is usually a sign of myocardial ischemia and will often require intravenous nitroglycerin immediately and optimization of heart rate and blood pressure. It might surprise you to know that in this context, pulmonary artery pressures can arise alarmingly in over as little as 90 seconds, and it requires immediate corrective action to prevent possible peri-induction myocardial infarction.
Here we see an example of invasive pressure monitoring as might be found in any cardiac operating room. But I really want you to focus on the light brown trace showing arterial pressure and the yellow trace showing pulmonary artery pressure, and the central venous pressure is shown in the bottom right hand corner. As the left ventricle becomes ischemic, its arterial pressure starts to gradually decrease and the pulmonary venous pressures increase, ultimately producing pulmonary hypertension, ultimately causing a stiff ventricle and causing severe elevations of pulmonary artery pressure.
So as we see, pulmonary artery pressure monitoring can be used as an index of left ventricular diastolic function during high-risk induction of general anesthesia with endotracheal intubation. This is why many cardiac anesthesiologists choose to insert a pulmonary artery catheter in selected patients while they are awake. The normal pulmonary venous waveform can be detected in the pulmonary veins, but cannot be detected in the normal pulmonary artery because pulmonary arterial pressures are so much higher. But by now, You should be very familiar with the concept of the single common chamber, and in diastole, the left heart, that is the left ventricle, the left atrium, and the pulmonary veins, are a single common chamber. When the balloon at the tip of the pulmonary artery catheter is inflated, the tip becomes isolated from the high pulmonary artery pressures, and because the pulmonary capillaries are low resistance circulation pathways, the catheter can now sense the downstream pulmonary venous pressures. In effect, the inflation of the balloon has allowed the left heart single common chamber to be extended retrogradely into a branch of the occluded pulmonary artery. This technology allows the early detection of rising pulmonary venous pressures as a surrogate for the reduced compliance occurring during myocardial ischemia. In the situation where myocardial ischemia causes pulmonary venous pressure to exceed pulmonary artery pressures, which are detected by the tip of the pulmonary artery catheter, then in effect, the left ventricle single common chamber has been projected so far backwards as to include the entire pulmonary artery circulation, and this is an extreme emergency requiring immediate treatment, which was usually, again, high-dose nitroglycerin and preemptive phenylephrine infusion to prevent systemic hypotension. So, the pulmonary artery catheter, with its balloon inflated through the application of the single common chamber concept, can measure left ventricular filling pressures to help detect hypovolemia in the management of hypotension. Even with the balloon deflated, the pulmonary artery catheter can also detect acute and rapid elevations of pulmonary venous pressure due to sudden decreases in left ventricular compliance in diastole as a surrogate index of myocardial ischemia. This can be an indispensable tool in carefully selected, very sick patients in the operating room or in the intensive care unit. Once again, thank you so very much for listening to this presentation.